We are lucky today to be joined by Dr. Alexander Walley for his grand rounds on using addiction consult services to address the opioid crisis. Dr. Walley received his medical degree from Johns Hopkins University. He went on to complete his internal medicine residency at UCSF, where he served as a chief resident. He completed additional training at Boston University in the clinical HIV/AIDS research training program, as well as a master's in science and epidemiology. Dr. Walley's research focus is on the medical complications of substance use, specifically in HIV and overdose. He provides primary care and office-based addiction treatment for patients with HIV at Boston Medical Center. Additionally, he manages the methadone maintenance program and staffs the inpatient addiction consult service at Boston Medical Center, which he founded in 2015. Dr. Walley currently serves as an associate professor of medicine at Boston University. He is additionally the director of Boston Medical Center's Addiction Medicine Fellowship and is the medical director of the Massachusetts Department of Public Health's Opioid Overdose Prevention Pilot Program. Please join me in giving a warm welcome to Dr. Alexander Walley.
Thanks so much, Matt, and thanks to the Chiefs for hosting me at a dinner last night. It was really nice. And I also want to thank Tim Brennan, who's my friend, and we've been working on in the field of addiction medicine for quite some time. And I look forward to continuing to work together. Okay, so I have no disclosures. I'm hoping to get through so we have some time for some questions. I'm going to start with the big picture. This comes from the New York Times. I think probably a lot of people have seen this slide. It's what oftentimes people start with when they talk about the opioid crisis. You see that there are what people are calling three phases of the opioid crisis. It started with prescription opioids. You can see in 2010 the line that's peaking there is our prescription opioids, so deaths associated with prescription opioids. And then you see this surge around 2010, actually, of another black line, which is heroin-related deaths, and then this exponential increase in 2013, 14, and 15 of fentanyl-related overdoses. And one thing it's in New England, we were. This is exactly the pattern that we saw. Typically, heroin has always come from New York City, that comes to New England. Something's different in the heroin market. I'm not going to get into it too much today, but we saw fentanyl before New York City. There's places in Massachusetts and in Rhode Island that are actually the points of origin for illicit substances now. And so there's a little bit of a difference in how and it's always evolving and dynamic. And that's actually one of the big lessons, I think, is that we don't know what things are going to look like 5 years from now. We know they're going to be different. And so the pace of change in the addiction world and the overdose world is really picking up. And so we're still in a reactive stance, but we have to do the best that we can do. In Massachusetts, when we recognized fentanyl, the health department asked for an EpiAid. An EpiAid is a program run by the CDC where they send usually EIS officers out to a local community to do good old-fashioned shoe leather epidemiology to figure out what's going on. And typically these are around infectious diseases. But there's been a series of EpiAids that have been around overdose that have happened in different parts of the country. We had one in Massachusetts. I was involved in that project, and it involved going to 3 counties in southeastern Massachusetts and doing 2 things: talking to people who had survived or witnessed an overdose, so the people who were living, and then reviewing the death files of the people who had died of an overdose. And so that was the mixed methods approach. I'm giving you the summary here of sort of the recommendations that came out of it. The first was you need to test for fentanyl if you're going to figure out anything about fentanyl. And actually, it's only about now that most of the medical systems are actually testing for fentanyl. We were an early adopter at our hospital. We've been testing since 2014 routinely, but a lot of other places are catching up. There was a recognition of harm reduction, actually explicitly in this EPI-8 for the CDC, recognizing that direct observation of anyone using illicit opioids is warranted, and along with that, ensuring that whoever is witnessing that person while they're using is equipped with naloxone. And then doubling down on improving access to medication for opioid use disorders. I'm going to make the case for medication for opioid use disorders if you don't already know it, but that was part of it. I'll just give this one quote that sort of summarizes that project. So now what they are doing is they're cutting the heroin with the fentanyl to make it stronger, and the dope is so strong with fentanyl in it that you get the whole dose of fentanyl at once rather than being time released. And that's why people are dying, plain and simple. You know, they are doing the whole bag, and they don't realize that they can't handle it. Their body just can't handle it. So in the midst of this, treatment has not kept pace with incidence. So I showed you that death curve. The concern is one of the ideas that we still need to figure out more about, but I think we're starting to see the answer. Is this just a problem of the deadliness of fentanyl, or are there more people who are using opioids who have opioid use disorder and are exposed? And it actually looks like we're seeing more and more people with opioid use disorder. So this is a claims database market scan with greater than 200 million commercially insured people in the United States, so a big fraction of the US. And just looking at opioid use disorder diagnoses between 2010 and 2014, you see an increase in the diagnoses for opioid use disorder of 0.12% to 0.48%. So that's a small fraction, right, of the people insured who had claims. But that's a quadrupling in the prevalence, or which you could consider incidence. However, if you look at the fraction in these commercial insurance plans that were receiving a medication for their opioid use disorder, that fraction went down from a quarter of the people with the diagnosis to 16%. That's really moving in the wrong direction at the wrong period in time. So it is good to diagnose more people, but it's also important to engage them in treatment. Now, you may be wondering about that 0.12 to 0.48% number, and I want to put that into context. There's major variation and really unknown what the true opioid use disorder prevalence is. The pool of people who are at risk for an opioid overdose is really not that well worked out. So what most people cite is the National Survey on Drug Use and Health, which is that first line there that gives us a 0.6% prevalence of US adults with opioid use disorder in 2016. We did a study using this novel individually linked statewide database in Massachusetts. It links 7 data sets, and we came up with an opioid use disorder prevalence of 4.6%. Now, just to give you context, the adult prevalence of diabetes is 8% and asthma is 9%. So this is looking far more extensive than I think we really understand. Now, on this long slide here shows you all states, and it shows their prevalence of opioid use disorder by state and payer in 2015. You can see the New England states and northeastern states have the highest numbers on the right, really because they have the most generous Medicaid programs, and those Medicaid programs cover treatment for opioid use disorder, and so they're going to have a higher prevalence because if you treat, then you're going to be more likely to diagnose. And you can see where New York is there. So almost 2% of the Medicaid population has an opioid use disorder in New York State. I think it's probably higher, but this is what you can see in claims data. So it's one thing to diagnose it, it's another thing to treat. So this is that same commercially insured database, and here we look at what happens after somebody's initiated on a medication for opioid use disorder. The top line that you see there is dotted. It says sublingual or oral mucosa buprenorphine naloxone, most popularly known as Suboxone. you can see that that medication does the best compared to the other formulations. And I think the one that you're most probably familiar with or heard the most about is injectable naltrexone, which is the gray line, also known as Vivitrol. So those are really the two lines to focus on here because the other medications really aren't prescribed in substantial amounts. And you can see that at 90 days, about 50% of people who were started on buprenorphine in this commercial data set are still on it. So 3 months, retention on treatment is about 50%. If you look at 90 days for injectable naltrexone, you're closer to 20%. And that continues to fall off. So I'm about to tell you how great these medications are, okay? But one of the major issues we have is that people don't stay on them. And they don't work if you don't take them. It's the same way as you have with antihypertensive medications or antibiotics. If you don't take the medications, they're not going to work. So I promise I am going to talk about the hospital here in a second. I like to lay this context to show you kind of what the stakes are. Where the hospital comes into my larger thinking about what to do about the opioid crisis is I think of it as a touch point. What's a touch point? It's a healthcare, a public health, or a criminal justice encounter where we can identify individuals at high risk for opioid overdose death. We can deliver overdose risk reduction services and or link and engage people in treatment. Examples of this would be a post-overdose situation, people who are incarcerated, people who are hospitalized, if they go into residential treatment, and something we have in Massachusetts, which is actually pretty common, called civil commitment. This is sort of spilling the beans here and telling you what I really think. We are missing opportunities to engage people. When people are treated with medication, their mortality is cut in half or more. When people discontinue treatment, they die. We need to make the treatment work for the patient and not focus on making the patient work for the treatment. So that's, if any of you are experienced in the addiction world, that last line may be familiar in that one of the things that has been a tradition in addiction medicine, which is kind of a self-fulfilling prophecy, is that the harder that the patient works for the treatment, the more likely the patient is to succeed. And so if you want to run a really successful treatment program, you should put up a lot of high barriers so it's hard for people to get into the treatment program, and then you're going to have a much higher success rate. Okay? But that, from a public health standpoint, is useless because it really leaves out the people that are at highest risk. Okay, so I'm going to look at one of the touch points, which is related to hospitalization, but is not exactly that, just to put a finer point on this. So this is looking at that same linked data set that we're using now in Massachusetts. And here we identified 17,000 overdose survivors between 2012 and 2017. We looked at these overdose survivors. These are survivors, right? Non-fatal overdose. At time 0 is when they had that non-fatal overdose. We're able in this database to look back 12 months before they had an overdose, and we're able to look 12 months after they had the overdose. Okay, so what happened? Well, you can see that not a lot of them are getting treatment with methadone, buprenorphine, or naltrexone before or after the event. So now I'm going to zoom in on the y-axis. Okay, so we went from 100% to 10%, and you can see that actually there are people that are getting these medications both before and after they have their overdose. You can see with the methadone line, there's a dip right before they have overdose, and that makes sense because a lot of a vulnerable time for people to overdose is when they are leave or discharged or no longer getting treatment. You see that a little bit with buprenorphine also. And then after the overdose, we actually do see an increase in the people who are getting medication. And if you add up all of the months after on any medication, actually 30% of people actually get a medication for at least 1 month. So that's pretty good. Well, it's not that good. It's better than 6% beforehand. It's moving in the right direction. 17% of those get buprenorphine, 12% get methadone, 6% get naltrexone. Now the real problem is the next number is how long people actually stay on the medication, right? So methadone's the best. People stay on it for 5 out of the 12 months. Buprenorphine, 4 out of the 12 months. And naltrexone, only 1 month. So this is really the problem with naltrexone, and it's not a fatal flaw for the medication, but it means we have a lot of work to do to keep people on these medications. And you'll see that this has serious implications for the survival benefit of the medications. So here's looking at the survival benefit, the survival curve. If you're on no medication and you have a non-fatal overdose, you have a 5% chance of being dead in the next 12 months. And if you do have a non-fatal overdose, you're probably, not always, but more and more, you're probably young and otherwise healthy with many years of productive life ahead of you. And now 1 out of 20 times, that's your risk of dying. That's a very high mortality rate for this population. We can cut that mortality rate in half or more by having that person be on a medication. So there aren't a lot of things in medicine. There aren't a lot of medications in medicine where you can decrease somebody's mortality rate from a chronic disease by 50% within 1 year. Well, these medications can do it. However, like I said, you have to take them. So this is internal medicine, and so I'll explain how we did this analysis. So here we changed the survival by incorporating the risk of the discontinuation month into our calculation of the risk of the medication. What's that mean? Well, so if I prescribe somebody a medication and they take it and it benefits them, that's great. Then if they stop the medication, their risk actually shoots up. We know this, and we observe this in this database, but this is a well-known issue that the actual highest time for overdose risk is the month after somebody stops their medication. There's a rebound effect, essentially. And so we incorporated that effect into this survival analysis here, and we show that all the benefit from naltrexone is actually erased because people don't stay on it. Buprenorphine and methadone is still retained, and that's largely because of the time that people stay on the medication. They accumulate survival benefits, so it makes it worth it even when they stop. Okay, so that I really wanted to give you that background, that case to sort of shine a light on why hospitalization is an important moment. And so I'm going to transition now and tell you about one of the cases. This is a patient of mine who was one of our first consult patients. And so we opened at the end of July 2015. She was one of our patients in August of 2015, 29-year-old woman who was admitted for incompletely treated MRSA, tricuspid and pulmonary valve endocarditis that was complicated by pulmonary renal emboli, pleural abscess, and pyomyositis. Now, previously, she had presented to the hospital with an abscess, and in January, and was diagnosed with HIV. And you can see there her CD4 and her viral load. She then, in May 2015, had an initial endocarditis episode, and as is custom at our hospital, she was initiated on antibiotics and then transitioned to a subacute rehab hospital. There's only one really in the local environment that will take patients like this. And she left that hospital on day 18 of antibiotics because she was being searched by security for possible drug use at the facility, which isn't uncommon there. Then she returned to our hospital in July of 2015, septic. She was admitted to the ICU. She was intubated. She was considered but declined by our cardiothoracic surgery colleagues for valve replacement because she had demonstrated that she wasn't adherent, she had active drug use, she had multi-organ infection and complications. Despite being refused for surgery, she actually, I'll get to it in a second, but she ends up surviving and getting treated medically. She had a history of hepatitis C that had cleared without treatment. She had overdosed multiple times and had been rescued by bystanders with naloxone. And her drug use pattern was daily heroin, cocaine, alcohol, and street pill use. And in Boston area, the street pill cocktail that we see are a combination of benzos, gabapentin, and clonidine. And so I'm going to get back to her, but now you imagine her sitting in the hospital in the ICU. She's she survived the ICU. She's going to come to the floor. This is I'm going to go through this paper that was done by folks in University of Washington in the early 2000s that I think really captures the baseline environment that occurs in a lot of academic medical centers and in general hospitals between providers and patients. Again, remember this is dated, but I think for a lot of us, the themes that you're going to hear still ring true. So the title of the paper was actually Mutual Mistrust, and they identified 4 themes. So the first theme was physician fear of deception. By the way, the researchers here went along daily rounds with the medical teams at the University of Washington and observed the interactions between the residents, the attendings, and the patients. So the first theme was physician fear of deception, physicians questioning the legitimacy of the need for opioid prescriptions with this concept of a drug-seeking patient versus someone with a legitimate need. So here's a junior medical resident said, when the patient is always seeking, there's a sort of a tone, always complaining and always trying to get more. It's that seeking behavior that puts you off. Regardless of what's going on, it just puts you off. The second theme that was identified, and here this is from a patient, was that there's no standard approach. The evaluation and treatment of pain and withdrawal is extremely variable among physicians and from patient to patient. There's no common approach, nor are there clearly articulated standards. The last time they took me to the operating room, put me to sleep, gave me pain meds, and I was in and out in 2 days. This crew, meaning on this time, it was like the Civil War. He's a trooper, get out the saw. The third theme was avoidance, and that was observed. So here they observed physicians focusing primarily on the familiar acute medical problems and evading uncertain areas of assessing or intervening in the underlying addiction problem. And pain and withdrawal were particularly problems. So this was a patient-resident dialogue. So the resident comes in and says, good morning, and the patient says, I'm in terrible pain. The resident, this is doctor attending, who will be taking care of you. I'm in terrible pain. We're going to look at your foot. I'm in terrible pain. Did his dressing get changed? Please don't hurt me. There's a patient fear of mistreatment. Patients are fearful they'll be punished for their drug use by poor medical care. I mentioned that I would need methadone, and I heard one of them chuckle in a negative, condescending way. You're very sensitive because you expect problems getting adequate pain management because you have a history of drug abuse. He showed me that he was actually in the opposite corner, across the ring from me. So when I first heard this as a, let's see, I was a medical resident when I first heard and read this study, and to me it really resonated. Now it's 16 years later. I'm not sure how much it is. I'm going to meet with some of the residents later today, and I'd like to hear about that. But I can tell you that this is what the stigma and the discomfort that we have when we encounter patients with addiction. That's what has really driven me to think about how to make things better, because it doesn't need to be this way, right? I'm hopefully going to show you that an addiction consult service and addressing addiction problems while people are medically hospitalized is one answer to it. I do want to plug the institution that I come from, Boston Medical Center. We now have the Graken Center for Addiction there, where one of the first things that the Graken Center has focused on is trying to improve the way Boston Medical Center as an employer deals with the stigma around addiction. And so you can see here a snapshot of the web page where they've created an employer resource library on how to really address the stigma of addiction among employers. It includes the fact that, unfortunately, the opioid crisis is so pervasive and, addiction in general, that our staff are all of us have been personally affected really in one way or another, not just through our patients. And so coming up with ways that the employer can be sensitive to that, I think, is important. One concrete example, in September, we celebrate what we call Recovery Month, and part of that includes a lot of training around addiction for the campus, including this Words Matter pledge. So really trying to change our language so that we're using non-stigmatizing language. And so we put up tables and ask staff as well as other visitors to the institution to take a pledge to use this non-stigmatizing language over I think what is, even in the New York Times continues, New York Times, for example, continues to use the term addict in its titles and in its, despite the fact that actually the AP style manual says that it's not appropriate to use it anymore. So, okay, so we'll get into sort of what this stuff is all about, what an addiction consult service is. So getting back to our patient, during her hospitalization, we had an addiction consult service, and we went and saw her, which she didn't have in the 2 prior hospitalizations. And so what did we do? Well, initially, we managed her withdrawal with methadone. We talked to her, and she really didn't want to be on methadone. She had had a bad experience previously, so we decided to transition her to 16 milligrams of buprenorphine, which stabilized her. She didn't actually go back to that skilled nursing facility. She completed her 6 weeks of antibiotics in our acute care hospital, which happens to some patients. And so we had plenty of time to spend with her. And during that time, we linked her to integrated HIV primary care and addiction treatment. And these are the things that she was able to do over the next 2 years. She engaged in that primary care. She had regular buprenorphine naloxone treatment. She became a very strong participant in 12-step with a sponsor and doing commitments on a regular basis. She obtained her own housing. She had been homeless, which I don't think I mentioned. She started working and was promoted to being a store manager. She had a healthy relationship with a man who had no addiction history, and she had daily contact and caregiving for her children. So, that's how easy it is. Just have an addiction consult service, and you can. I promise you, I'll give you more details later on. It's not so simple, but this is what we're looking for, and this is true. This is what happened to her. We're not just doing this out of the kindness of our own heart. The opioid crisis is hitting hospitals in a way it hasn't before, and if you want to look for risk, the hospital is a touch point. So here we have data from Massachusetts, which shows the number of opioid-related hospital discharges, growing 50% in 4 years, essentially. So that's showing you that we're really seeing this, and it's a crisis for hospitals. In-hospital mortality rates for people in general is going down. In-hospital mortality rates, so that's good news. It's kind of surprising to me, considering how the patients in the hospital are so much more acute than they used to be. At least I think that's what we all think, right? These are sicker patients in the hospital now than 20 years ago, but they're not dying as much in the hospital, unless, of course, their admission is related to opioids. So the in-hospital mortality for patients who have opioid-related issues has been going up, while it's been going down or staying flat in other conditions. This is data from Boston Medical Center looking at the inpatient services, right? This is the breakdown in the percentage of adult discharges with a billed substance use code during the visit. And number one is the ID service. We have actually an ID service that admits and discharges patients, not just an ID consult service. Right after that is internal medicine. We're talking about a third or more of the patients on these services have a substance use disorder that goes on the discharge summary as one of the billable diagnoses. You can see here that, what's not on here I think is pediatrics. I don't see pediatrics, but even the renal service, 10%. So every service is facing patients with substance use disorders. Nobody's really immune. Across all adult dischargers, 17.5% had a primary or secondary substance use code billed during the hospitalization. We think these are probably undercounts, as substance use is not always coded when it is not primary, right? So, substance use sometimes is primary, but usually not. So an overdose, it would be primary. If somebody comes in with aggravated alcohol withdrawal, but people are not admitted to our hospital for opioid withdrawal as a primary diagnosis. That is only a secondary diagnosis. So the readmission rates among these patients, again, this is our hospital data, are they are higher and they have longer lengths of stay. So the 30-day readmission rate is 16%, people with an active substance use, 12% in those who don't have active substance use, and the length of stay is over a day longer. So in this context, you can see this is July, August 2015, right when we started the service. We did a survey of medical residents, 30 medical residents, and 40 nurses on one of the medicine floors. Only a third of both groups were satisfied with the substance use disorder care provided at BMC. There was very little enthusiasm for the idea that the care was integrated with the rest of the medical care. Lots of belief that we needed a new approach and that a consult service would be useful. And so this just points out that while we focus on the patients, the care providers are an important piece of this. Taking care of these patients in a non-integrated way is not satisfying, and I think really can undermine morale. So we started the addiction consult service with these goals in mind. We wanted to improve care quality, including the initiation of evidence-based treatment, which is, in the case of opioids and alcohol, largely medications. We wanted to link patients to high-quality care on discharge, reduce readmissions, optimize length of stay. I say optimize because what also is associated with substance use disorders is, against medical advice, discharges, which would shorten length of stay. So what you ideally want, actually, if you just got rid of the AMAs, you'd lengthen the length of stay, right? And that would actually be a good thing. Because there's a lot of harms that come from against medical advice discharges. And we wanted to rationalize the emergency department use, as well as improve staff satisfaction and provider knowledge and skills. The scope of the service, although it's actually expanded now, is to offer consultation Monday through Friday to all inpatient services with pager availability on nights and weekends, either from a fellow or in attending. We actually just, with DISREP money, been able to expand to Sundays because Mondays are quite busy for us now, and offloads the Sunday Monday if we can have a nurse practitioner come in on Sundays. There's a lot of collaboration that was built in from the beginning, so daily coordination with floor social work, bi-weekly rounds with the psychiatry consult and liaison service. We have a tobacco team that is quite robust at BMC, but they're not able to see our addiction patients, so we actually take on the tobacco team needs for the patients that are getting our consults. And then we have a super utilizer care management program which we work very closely with because they've realized that there's lots of overlap. There's also multiple working groups where we work. Here's our staffing pattern last year and this year. So it includes an attending who comes in rounds in the afternoon and sees all the new patients and any of the follow-up consults that are needed to be seen. We added in this last year, like a year ago, we added a nurse practitioner who is full-time, and the nurse practitioner performs all the new consults, doesn't perform all the new consults. The nurse practitioner can perform new consults and do follow-ups. They can write notes and bill. They do get oversight from the attending. There's a transitions focused, it was a nurse and now we moved to a social worker who really focuses on discharge planning as well as doing in-hospital what are called biopsychosocial assessments that really set people up for admission to an addiction program when they leave. And then we've about to add a wellness peer advocate, which you're going to hear if you talk to people who do consult services elsewhere, as a valued member of the team, who really is on engaging the highest risk patients in the hospital and then trying to facilitate that linkage on outpatient. And so you can see how our team is growing from last year and this year, and how it's going to be able to increase our capacity to be able to meet the need. This is a schematic that kind of shows how we visualize somebody's move through the hospital and what the consult service does and who does it. So, we try to have the whole team involved to the degree that the patient can handle it up front. being sensitive to, trying to keep them in the hospital engaged in their medical care. We need to find out what their story is and what they're interested in. The physicians and the nurse practitioner are really focused on the medical management and advising the primary team, and as well as thinking about what the plan will be for their post-discharge. And then for that discharge, we have our social worker and peer heavily involved. Everyone sort of owns responsibility for doing motivational interviewing and harm reduction counseling, which are done in small bits, sort of very patient-centered. So that's not enough. I mean, I know that slide's complicated, and we have a lot on this team, but there are also these elements. So effective initiation of medication for opioid use disorder for inpatients really relies on relationships with provider partners. And I know, I dream about having the access to methadone that you have in New York City. We have waiting lists at every single methadone clinic, and they're it's very difficult to open new methadone clinics. You have capacity in New York City. It's really important, and this relationship expedites access. We can't get access without having a good relationship with these clinics. It enables methadone titration as needed while inpatient. So if the case that I presented, if she had decided she wanted to stay with methadone, we would have been able to titrate her up over the 6 weeks to a really effective dose of methadone over time, which would have been ideal. And then we could have transitioned her directly to the methadone program. We decided to start a discharge clinic along with, even though we have very good access to outpatient buprenorphine treatment, some of the patients that we were initiating were still not stable from an addiction standpoint when they left our clinic, and because of the nature of what's available in Boston, they weren't a good match for the existing community programs right away, and we were very concerned that linkage would be dropped. And so we created a low barrier access clinic, which was staffed by addiction physicians and nurses. It allows newly discharged patients to be seen frequently until long-term program is found that's suitable for them. It really works for unstable patients who may not meet criteria for their traditional outpatient programs. It's also, this is number 3, is still where we have a work in progress, which is partnering with programs that can offer further inpatient care. We see a high burden of patients who have homelessness, and discharging them to a shelter with a medication, while it's better than discharging them to a shelter without a treatment plan. Ideally, they need to be in some sort of setting where they have a roof over their head and they have reliable access to their medications. And so those facilities exist, but they're not friendly to our patients. And so we have subacute rehab facilities that are refusing our patients because they have an addiction, and you have addiction programs that are refusing our patients because they're too medically complicated. And so where people end up is a homeless shelter with nothing, right? So that's a real gap in our system that we're working to address, and the best way to address it, honestly, is by making relationships with one program at a time, and we've started to see some improvement in that. Okay, so some outcomes or some descriptive data from our initial 6 months of when we started the consult service, and this has sort of held true since then. While alcohol use disorder is the most common substance use disorder among patients admitted to the hospital, in our hospital, opioids is really where we've been getting the most consults. And I think that's because of the medication for opioid use disorder, the withdrawal syndrome, which of course happens with alcohol also, but the general medical teams don't really need our help in addressing your run-of-the-mill alcohol withdrawal. And so opioids is where we're seeing the majority of our patients. We see stimulants, but oftentimes the stimulant users are using another substance like alcohol or opioids. Benzodiazepines is next. Here you see very low in the first 6 months back in 2015 of methamphetamines, although we're starting to see a surge of methamphetamine in our local community. And I think if we redid this for the numbers most recently, we'd see a higher methamphetamine. But a lot of the methamphetamine we're seeing actually is in combination with opioids. And so what we did with these patients from the first 6 months was we looked to see how often they linked to care. And that's what you see here, follow-up rates by medication. And I say glass full, glass empty here because I think there's good news and bad news on this slide. The best news actually was with methadone, where we had 76% of the people we initiated on methadone actually linked to a methadone program, which if you look at the randomized controlled trials that look at this effort is actually right in line with what the randomized controlled trials. And those trials actually select people. They're more selective than we were on the consult service. Buprenorphine actually, 50% of people link, which also matches up with some of the controlled trial data. So this is one of the reasons why we really tried to beef up this discharge clinic, was to try to make a place where people could get access to for buprenorphine the next day and not necessarily wait a week, because we found that if people were waiting longer, they weren't as likely to make it. Naltrexone for alcohol use disorder, as I showed you earlier, it's really a work in progress. We have a long way to go. And I think with our daily discharge clinic, we've done a better, hopefully we've done a better job, but it's time for us to look again. And then naltrexone with alcohol use disorder, there is some linkage there, but not optimal, not where you'd like to be. Obviously, 100% is where you want to be here. Just a brief slide I wanted to insert about methadone. So can you start methadone in the hospital? And the answer is yes, you can. There's debate about this, but we've been doing it now for 20 years, I think, at our hospital. Even before we had a consult service, we had a relationship with a methadone program where we would start people. And so starting methadone or buprenorphine in the hospital is both legal and advisable. Here's the specific section of the code in the Code of Federal Regulations. And then I also cite here a paper that by NASCA in the Journal of Addictive Behaviors and Therapeutic Rehabilitation, which really walks people step by step through what the legal and regulatory issues around initiating methadone in the hospital. I think direct linkage is really important. It's the opportunity to capitalize on a reachable moment, and then risking undoing all of the progress achieved during hospitalization. That's one of my frustrations, if you have somebody in the hospital getting IV antibiotics for weeks and weeks and weeks, and they do stabilize, and they leave the hospital happy, we really need to figure out how to get them a chance when they leave the hospital to not lose what they've gained. People who are directly admitted are successful in treatment, and we know it's pretty clear from study after study that in the case of opioids, people die while they're on waiting lists. Here's two studies that really are example of making the treatment work for the patient by initiating medication at venues for high-risk patients. The one on the left was the STOP study that was done in Massachusetts at our hospital, where we randomized people to initiate buprenorphine in the hospital and be linked versus being tapered off of buprenorphine and being referred. So it was linkage versus referral, or let me say titration and linkage versus taper and referral. And the linkage was much higher in the titration group, 72% versus 12%, remaining on bup at 6 months, so 17%. Now that's lower than what you saw in that commercially that commercial database slide that I showed you. But remember, these are higher risk patients. They're less stable. They're more likely to leave treatment. So there's that 17% needs to be higher, but it's a lot better than the 3%. And then median days of illicit opioid use in the last 30 days at 6 months, it's much better in the group that received linkage. The next study is the one by D'Onofrio at Yale, which is a very similar approach in the emergency department. You see somewhat similar numbers, although it looks like those folks 78% linked to outpatient care versus 37%, reduction in use, and then admission to inpatient treatment. So here they actually looked at whether people were spared from going into an inpatient treatment if they were started on a medication, and it looked like there was less inpatient treatment utilization with the medication. There's now emerging studies, more and more coming out now, which is making the case for hospitalization. I'm going to run through, I think, some of the kind of key ones that informs our thinking. So first of all, most inpatients in the hospital want treatment. Inpatients with substance use disorders want to stop, about 2/3 of them, and they want to take addiction medications, about half of them. So this isn't an issue of you not having the patients wanting it. And so that comes out of Portland, Oregon Health Sciences. I just went through the buprenorphine inpatient study. A similar observational project was done at our hospital around methadone, which shows that methadone maintenance engages people after discharge. There's a nice one that's been done in San Francisco General Hospital around alcohol medication initiation and discharge, which reduces 30-day readmission rates. So this is actually initiating injectable naltrexone for alcohol. And then addiction consult services specifically can effectively deliver evidence-based care. Our project, I think, showed that you can diagnose and treat in the hospital and link to outpatient care. Mass General has an addiction consult team, which has shown that increased post-discharge abstinence and reduced addiction severity after discharge. So I think promising and accumulating evidence for these programs. I wanted to focus just for a couple slides on, I think, this pertains to the patient that I presented. I think this is an area where there's the highest opportunity, both the highest risk, highest opportunity for reward, and that's with patients who have infections from injecting drugs. We're looking at endocarditis, injection drug-related endocarditis versus non-injection drug-related endocarditis at Mass General. In the Brigham, they had a lower 30-day mortality in the injection drug-related endocarditis, but they had a higher valve reinfection rate. So I think that sort of makes a lot of sense. The folks in the injection-related group are younger and healthier than the people in the non-injection-related group. So the opportunity to treat their infection effectively and allow them to have good outcomes is there. But if they continue to use, then they're going to reinfect. And so, this is, I think, an area where we have a lot of progress to make. This has been recognized by ID providers. I found this perspective in the New England Journal particularly poignant. So it was called Stretching the Scope, Becoming Frontline Addiction Medicine Providers. At some point, it became culturally acceptable to treat all conditions in a patient except addiction. The history of medicine is in part the history of physicians stretching the scope of their practice to answer the pressing needs of their time. So it's really a call to action among infectious disease providers to bring this into part of what they do. Now, I can tell you that I know, because I work closely with the ID providers at our hospital, ID providers are under a lot of stress. They're being asked to do a lot with less. And so to put this all on ID providers, I don't think is the way to go. But they are ones in these hospitals that are seeing these patients. And so I think we need to, in some cases, they're going to be the ones that step up, and they need to be supported. The IDSA recognizes this. So infectious disease and HIV clinicians are increasingly concerned about the role of the opioid crisis, increasing incidence of infectious diseases. Physicians report that up to 25 to 50% of their inpatient hospital consultations are from infections in patients who inject drugs. Failing to prevent and treat the infections and the addiction leads to increased deaths and to severe public health consequences. So this isn't just about addiction medicine, it's about all of medicine. And with that in mind, we have this as our addiction medicine consultants checklist, and you can see that we need to understand the patients, where they're coming from, with their history, where they want to go with their treatment or their harm reduction. We need to offer them treatment. We need to have a plan if they're not ready for treatment, but we also need to take responsibility for their other risks and think about, if they're injectors, how can we help them decrease the burden of HIV, Hep C, and Hep B, as well as STIs. And then also understand that we're not going to get very far unless we address the concrete needs of these folks. And that's why we, as best as we can, need to partner with our social work colleagues and where peer workers can really make a difference. Okay, so some of the successes that we've had in instituting this, from our perspective, from the team's perspective, is starting medication and linking people. It's very gratifying to see a patient, including the patient that I'm presenting, in your outpatient clinic after they were initiated, in the hospital when they were very ill. Some unexpected benefits are the enthusiasm around trainees, which I'm going to get into just for a minute, as well as the gratitude from our colleagues in the hospital. So a lot of that frustration that was, I think, delivered at oneself as well as the patients around the discomfort of taking care of these patients has transformed into gratitude for the fact that we're there to help. And people come to the addiction consult service with their problems, managing patients. So, we're an outlet for that. The collaboration with outpatient programs in psychiatry, we've had some billing success. There's been a synergy with the hospital's concurrent efforts to reduce readmissions and in our case, establish an accountable care organization. Our hospital sees this as really a key tool that we have in reducing global costs. And then there's challenges. You have to find the right staff that really want to do this. They have to, it helps if they come in and they stick with the program, which we've been very lucky to retain everyone that we've brought into the team. Post-hospital dispositions are still, can be an issue, and you need to establish a clear owner who's dedicated to finding people a spot and has access to spots. Tracking outcomes is important. We think, actually, we'd really like to do a better job of tracking across multiple hospitals, not just our own, and then proving to the hospital that it is worth sustaining. So while I think we're on their good side, I feel like this is a constant battle and important for us. This is really reviewing kind of the key elements of the project, the staffing, in-hospital supports. I didn't mention pharmacy. So pharmacy is really your friend, and we have inpatient clinical pharmacists who help us. I didn't mention them as part of the team, but they can do naloxone training, for example. If we're not so sure whether a buprenorphine prescription is going to be filled, we can run it by them in advance, and they'll make sure it gets filled. So pharmacy is really an important friend. I mentioned that there are these other elements that are really important. They're largely relationships with post-discharge providers. So just a minute about, let me just check our time here, see how I'm doing. Ooh, I am right at it. Okay. I'm gonna sprint ahead and just say that this is incredibly valuable for trainees, and it's also gratifying. And I know that Mount Sinai is really dedicated to both resident and medical student education, and this is an asset. We have a lot of interest on our consult service. They're strong contributors and enthusiastic providers. Okay, so what happened with our case? So in August of 2017, she completed a buprenorphine naloxone taper. Okay, so I just told you how important it is to retain a patient on medication. This patient decided she wanted to taper against my better advice. Her mother told her she shouldn't need a crutch in her recovery. And we didn't do so well in the face of that sort of pressure from the family. Then a couple months later, she actually tapered and did fine until a couple months later, the father of her children died of an overdose. She had grief and decided to take time off from work. She really started to have some serious depression symptoms. In January 2018, she relapsed to heroin and cocaine, was still working intermittently. Then March 2018, while she was under the influence, she had a motor vehicle crash. Ended up going to detox from the hospital, did not make us aware of anything that had happened. I think she was feeling embarrassed or shameful and wasn't ready to come back into treatment at that point. But then she re-presented to our hospital with fever, myalgia, abdominal pain, arthralgias. We were, of course, thinking about endocarditis recurrence, which we were very concerned about. Turned out she had very high liver enzymes, and in the end, it turned out to be hepatitis C reinfection. At that time, we got an addiction consult. We restarted her on buprenorphine, her antiretrovirals, and re-engaged her in outpatient care. She ended up clearing hepatitis C for a second time spontaneously, and we stabilized her on buprenorphine and her antiretrovirals. And right now, she's living happily ever after. But it's important for you all to realize that this is a relapsing, remitting chronic condition. And so we shouldn't be surprised that she went through this, but her relapse period this time around was shorter than it had been in the past, and her recovery periods are hopefully become longer and longer. Next steps to improve hospital practice for addiction medicine. So, because we do not have all the answers. There are still lots of great questions. If you want to do research, this is a hot area, I would argue. How to optimize linkage on discharge. How to best care for people who don't want treatment. What else to offer inpatients besides medications? How to best meet the needs of special populations like peripartum women, adolescents. Adolescents and young adults are really difficult. I'm looking to Tim because he has some pediatric background to help with that. But people with chronic pain. How much specialty knowledge is actually needed and who should deliver it? How do we train the workforce? I think that an addiction consult service is a great place to start. How best to motivate systems and institutions? Should we mandate things? Should we have guidelines? None of this is really clear at this point, but hopefully will become clearer. Thanks so much. I really enjoyed being here. I don't know if there's time for questions, but I'm going to stick around. There's my email address. If you have questions or comments, please let me know.